Assalamu alaikum everyone. I am Dr. Zubair Ashraf, consultant pulmonologist here, and today we will be discussing an important topic, respiratory failure and oxygen therapy. All of you must have seen patients with respiratory failure regardless of whichever department you are working, because it is a common presentation in all the departments including medicine, peds, ICU, emergency, even surgery and gynae departments. We also see patients with respiratory failure. Okay, here are few clinical scenarios, and if you can go through them quickly. First scenario is a 65-year-old male with acute MI having respiratory rate 26 per minute and saturation of 96% on room air. So for each scenario you have to tell whether this patient needs oxygen or not, and if the patient needs oxygen, how will you give oxygen, which device will you use, and how much will you keep the flows, initial flow. So first scenario, a 65-year-old male with acute MI having respiratory rate of 26 per minute and saturation of 96. What do you think? Sorry? So we will not give oxygen. And second, a 70-year-old male chronic smoker with dyspnea, respiratory rate of 30 per minute and saturation of 86 per minute percent. Will you give oxygen? And how will you give it?
CO2
88 to 92, you are saying that the patient may be hypercapnic. तो फ़र्ज़ करें अभी आपके पास ABGs की नहीं है वैल्यूज़ अभी, या ABGs की फैसिलिटी ही नहीं है, तो फिर ऑक्सीजन देंगे या नहीं देंगे? देंगे, कैसे देंगे? 2 लीटर वाया नेज़ल प्रॉन्ग। सारों को यही आंसर है या कोई डिफरेंट इसमें ओपिनियन भी है? वाई 2 लीटर? तो मिनिमम तो 1 लीटर होगी, 1 to 2 लीटर यूजुअली स्टार्ट करते हैं, लेकिन उसमें हम क्या मॉनिटर करेंगे या टारगेट क्या रखेंगे? ठीक। सो पेशेंट प्रोबेबली हैज़ गॉट COPD, क्रॉनिक स्मोकर है, डिस्निया एंड की हिस्ट्री है पेशेंट को, तो इन पेशेंट्स हु आर एट रिस्क ऑफ टाइप 2 रेस्पिरेटरी फेलियर we will keep the target 88 to 92. Third scenario is a 20-year-old female type 1 diabetic with vomiting, respiratory rate of 30 per minute and saturation of 98% on room air. No need of oxygen, saturation is 98%, but the respiratory rate is 30. So any idea what could be the reason? It is compensatory due to metabolic acidosis. Patient is hyperventilating due to metabolic acidosis. And fourth and last scenario, a 55-year-old previously healthy male with fever, productive cough, BP of 85 by 50, respiratory rate of 28 per minute and saturation of 80% on room air. So patient needs oxygen, patient is hypoxic. How will you give oxygen and how much oxygen will you give? ऑप्शंस क्या हैं? नेज़ल कैनुला से देंगे, फेस मास्क से देंगे, वेंचुरी मास्क से देंगे, या फेस मास्क से स्टार्ट कर सकते हैं. कितने फ्लो पे करेंगे? अगर 1 to 2 लीटर से करना है तो वाई नॉट नेज़ल कैनुला? चलें अब हम स्टार्ट करते हैं और आगे फिर ये डिस्कस करेंगे सिनेरियो. So learning objectives are define what is respiratory failure and understand its types and causes, how to assess and manage respiratory failure, what are the various oxygen delivery methods which we have and which one to use when, and then what is the role of different team members in care of patients with respiratory failure. So respiratory system comprises of airways and lungs, and the two main functions of respiratory system are oxygenation and carbon dioxide elimination, to provide or supply oxygen to tissues basically, not just inhaling oxygen. तो मेन जो फंक्शन है रेस्पिरेटरी सिस्टम का टिश्यूज़ को ऑक्सीजन सप्लाई करना है. Obviously it needs help from other organs, circulatory system as well for this function. What is happening in alveoli? In alveoli there is gas exchange, oxygen moves in the blood. Blood is coming from the pulmonary artery, and from the alveoli oxygen goes in, carbon dioxide moves out, which is later exhaled. So from deoxygenated blood, the blood becomes oxygenated. So how do you define respiratory failure? Any idea what is the definition of respiratory failure? When we will say that this patient is in respiratory failure?
This is divided into two parts, type 1 and type 2.
That is
related to oxygen, low level of oxygen in the blood, and type 2 is definitely close to carbon dioxide.
Yes.
Higher level of carbon dioxide in the body, type 2 respiratory failure.
Yes, so the basic thing, the main thing on the basis of which we define respiratory failure is oxygenation. Because we cannot measure tissue oxygenation, we depend upon arterial oxygenation, which we can measure with ABGs. So mainly जो definition है ना, that needs ABGs. So in ABGs, if PaO2 is less than 60 millimeters of mercury, then that means that there is respiratory failure. So PaO2 is less than 60, या PaCO2 is more than 45, and both can be acute or chronic as well. Type 1 is only hypoxemic respiratory failure with reduced PaO2 less than 60, then that means the patient is in type 1. PaCO2 will be either normal or it will be reduced less than normal. And in type 2 there is hypercapnia along with hypoxia of PaO2 less than 60, there will be hypercapnia of PaCO2 more than 45. So this is how the respiratory system, the breathing system is controlled from CNS, peripheral nerves, the respiratory muscles and chest wall. They are basically the mechanical factors involved in the breathing system, and airways and alveoli is the place where there is gas exchange. So इसमें से the first 4 components, they act as the respiratory pump. इनका काम है alveoli तक एयर पहुंचाना, ऑक्सीजन पहुंचाना. They are not involved in the gas exchange. Gas exchange is only happening here in the alveoli. So अगर हम इस हिसाब से देखें कि टाइप 1 कौन सा करता है और टाइप 2, तो इनमें से ये the first 4 components, they usually cause the abnormalities of these first 4 components. It usually causes type 2 respiratory failure, while the abnormalities of alveoli, it causes type 1 respiratory failure. So जब type 1 respiratory failure होगा, pure type 1 respiratory failure, usually they can coexist as well, type 1 and type 2. But अगर pure type 1 respiratory failure है, तो you have to think about that there is something wrong in the alveoli. So इसमें again same चीज़ें हैं. The examples of type 1 respiratory failure are pulmonary edema, pneumonia, pulmonary hemorrhage and pulmonary embolism. What happens in pulmonary edema? In pulmonary edema, usually there is fluid in the alveoli. Alveoli में fluid आ जाएगा, their gas exchange में oxygen cannot be absorbed through the alveoli. In pneumonia, there is pus or again fluid in the alveoli. And in pulmonary hemorrhage, there is blood in the alveoli. पल्मोनरी एम्बोलिज्म में क्या होगा, जो हमने देखा था कि बाहर से जो ब्लड जा रहा था उसमें रुकावट होगी, ब्लड सप्लाई कम होगी, तो वहाँ से ऑक्सीजन तो होगी एल्वियोलाई के अंदर, बट इट कैन नॉट बी एब्जॉर्ब्ड इनसाइड द ब्लड. So all these problems are at the level of alveoli, so they are causing type 1 respiratory failure. These are various mechanism or pathophysiology which is involved in the respiratory failure. There can be alveolar hypoventilation. There can be ventilation perfusion mismatch, which means that the alveoli, they are ventilated but perfusion is low, such as in pulmonary embolism. And shunt, any example of shunt? Shunt can be intrapulmonary or it can be extrapulmonary intracardiac shunt as well. So what usually happens in shunt? Any idea? Yes, so deoxygenated blood does not reach the alveoli. It bypasses the alveoli. It can be due to AV malformations. It can be due to shunt in the heart like in ASD or VSD. बजाय इसके के ब्लड जाके लंग्स के थ्रू ऑक्सीजनेट हो और फिर जाए, लेकिन ब्लड फ्रॉम राइट साइड ऑफ द हार्ट गोज टू द लेफ्ट साइड ऑफ द हार्ट डायरेक्टली. Cyanotic, congenital cyanotic heart disease, ASD, VSD, PDA. AA gradient क्या होता है और इसका क्या क्लिनिकली क्या यूज़ है? AA gradient or AA difference, it is also called as. So this is the difference between alveolar oxygen level and arterial oxygen level. So it can differentiate between causes of hypoxia. अगर environment में कम है ऑक्सीजन तो alveoli में भी कम होगी और उसकी वजह से arteries में भी कम जाएगी. So like in high altitudes the AA gradient is normal, but in hypoxia due to any reason which is involving the alveoli, the AA gradient will be increased. Usually it is less than 5 to 15, but it increases with age as well. So hypercapnic respiratory failure, शुरू में हमने बात की थी कि इसमें जो hypercapnic respiratory failure PCO2 ज़्यादा होती है, it can occur in any condition once the respiratory muscle start getting fatigued. इनिशियली जो नॉर्मल ये होता है कि वेंटिलेटरी सप्लाई ज़्यादा है, यानी हमारे लंग्स की जो कैपेसिटी है टू एलिमिनेट कार्बन डाइऑक्साइड इज़ वे मोर देन द नॉर्मल वेंटिलेटरी डिमांड जो रेस्ट पे डिमांड है. ऑब्वियसली विद एक्सरसाइज और इन डिजीज स्टेट ये डिमांड बढ़ती है, लेकिन फिर भी यूजुअली इवन अप टू 10 टाइम्स देन नॉर्मल जो है ना वेंटिलेटरी सप्लाई कैन बी एडजस्टेड टू मीट द वेंटिलेटरी डिमांड. बट इफ़ अगर उससे ज़्यादा बढ़ जाए वेंटिलेटरी डिमांड तो फिर वेंटिलेटरी सप्लाई जो हमारी बॉडी की है इट कैन नॉट कोप एंड इट कैन नॉट मीट दैट डिमांड एंड दैट लीड्स टू रेस्पिरेटरी फेलियर. These are various CNS abnormalities which can lead to respiratory failure. उसमें मैकेनिज्म सबका जो अंडरलाइंग वो ये है कि मेडल्ला में जहाँ पे रेस्पिरेटरी सेंटर है, there is pathology in medulla which can be stroke, which can be tumor or AV malformation which leads to retention of carbon dioxide, hypoventilation and obviously overdose या sedatives अगर overdose है narcotics की, opioids की, that can also present as type 2 respiratory failure. There are some metabolic conditions as well. मिक्स एडीमा, सीवियर मिक्स एडीमा. रिसेंटली हमने एक पेशेंट भी हमारे पास आई थी मिक्स एडीमा कोमा के साथ, सो शी वाज इन टाइप 2 रेस्पिरेटरी फेलियर. Similarly, hepatic failure and renal failure can also cause due to their central effect. Similarly, because the control of breathing or respiratory system is through the peripheral nervous system, the brain sends the signal to the lungs through the peripheral nerves. If there is pathology of peripheral nerves like myasthenia, GBS, ALS, this can also cause type 2 respiratory failure. And similarly in muscular weakness as well, there is type 2 respiratory failure and restrictive pattern of lung disease. Airways, upper airway abnormalities and lower airway abnormalities both can cause respiratory failure. Acute epiglottitis, foreign body inhalation and tracheal stenosis, as sometimes happen after prolonged intubation, they can also result in respiratory failure. We already know about COPD, asthma, the lung diseases, they can cause type 1 and type 2 respiratory failure as well. Abnormalities of alveoli we have already discussed. Whenever there is fluid pus in the alveoli, it leads to reduction in oxygen absorption and leads to respiratory failure. So, clinical evaluation of a patient who has presented with respiratory failure, reduced oxygen levels is important, and it depends upon symptoms and clinical examination. Symptoms, the history is important in differentiating acute from chronic respiratory failure, because management can be different in both cases. Usually there will be symptoms due to hypoxia, which can be dyspnea, restlessness, headache, confusion and drowsiness. Eventually develops due to severe hypoxia or increased carbon dioxide level. Hypercarbia can also cause drowsiness. And then there will be general signs of respiratory failure, tachypnea. Patient may be using accessory muscles, cyanotic, and again altered mental status. Then there will be findings related to the cause of the respiratory failure. But systematically you have to work, think of the causes like जो हमने 5 इसमें देखे थे कि starting from the CNS. तो जब हिस्ट्री लेंगे डिटेल में, यू हैव टू फोकस ऑन द ग्रुप जो कि ज़्यादा इन्वॉल्व है. इफ़ द पेशेंट हैज़ रेस्पिरेटरी फेलियर ड्यू टू इन्वॉल्वमेंट ऑफ द पल्मोनरी सिस्टम, पेशेंट विल हैव हिस्ट्री सजेस्टिव ऑफ दैट. कफ की हिस्ट्री होगी, COPD का, स्मोकिंग की हिस्ट्री होगी. अगर पेशेंट को CNS के सिम्टम्स की हिस्ट्री है तो दैट विल then there will be cause in the CNS. So basically history में आपने focus करना है जो आपका suspected जो group है of diseases. So clinical suspicion on the basis of history and initial presentation, whether the patient is in emergency, in indoor or ICU. Then obviously you will do screening with pulse oximetry, and you will confirm the diagnosis of respiratory failure with the help of ABGs. And then you have to do some investigation to look for the underlying cause. Underlying cause, as I told you earlier, can be in any of the 4 or 5 systems we have discussed. Okay, इसमें how on the basis of ABGs you can differentiate or you can suspect the causes of respiratory failure. In CNS, if there is involvement of CNS, then usually there will be acidosis and increased PaCO2, respiratory acidosis, and type 2 respiratory failure in CNS, peripheral nervous system or muscular diseases में same टाइप 2 रेस्पिरेटरी फेलियर होगा. जो एयरवेज में इन एक्यूट एजमा यूजुअली देयर इज रेस्पिरेटरी alkalosis, at least in the beginning, because patient is hyperventilating, trying to compensate for hypoxia. But once the patient starts getting fatigued, then the asthmatic patient can also go into type 2 respiratory failure. And the PaCO2 will either become normal or it will start to go up. So that is a warning sign that patient may need intubation. So that patient should be ideally admitted in HDU and carefully monitored. In COPD, there will be two type of patients who are in chronic type 2 respiratory failure, or those patients who have mild COPD, but even in moderate to severe COPD there will be some patients who have type 1 respiratory failure. So in those cases you will have to do ABGs to differentiate between the two. How will you decide where you want to manage these patients with respiratory failure? Patient comes in emergency, on the basis of which factors will you decide whether the patient should be admitted in ICU or whether patient can be admitted in the ward or on floor as well? New score, if the patient is vitally unstable, hypotensive, then that is one of the indications for HDU or ICU admission. Acuity, how long the patient is having that disease. For example, हम COPD के patient देखते हैं, although they are hypoxic, although they are in type 2 respiratory failure, but they are otherwise stable, they are coping well with the failure. So अगर mild failure है, patient is conscious oriented, ABGs पे mild acidosis है, बहुत ज़्यादा severe acidosis नहीं है, then that patient can be admitted in the room or ward as well, obviously with monitoring. Then degree of hypoxemia, hypercapnia, patient की oxygen demand बहुत ज़्यादा है, 8 to 10 liter patient oxygen demand है, severe acidosis है, pH is less than 7.25, then that patient should obviously need to be admitted in the ICU or HDU. And similarly, we have to consider the comorbid conditions like heart failure, renal failure. If they are present, then patient will need more monitoring. If patient is hypotensive, again will need monitoring and may need inotropic support as well. So treatment approach is same. Initially, you have to do the ABC, airway, breathing and circulation, and start oxygen therapy depending upon what is the type of respiratory failure. In type 1 respiratory failure, you have to aim for 94 to 98%. In type 2, you can aim 88 to 92%. And monitor, escalate if needed to NIV or ventilator, and obviously treat the cause. Oxygen therapy, we discussed few scenarios in the beginning. Oxygen is treatment for hypoxemia, not breathlessness. एक patient है जो breathless है, respiratory rate ज़्यादा है, लेकिन saturation अगर normal है तो that patient does not need oxygen. तो उस पेशेंट में आप देखें कोई और रीज़न तो नहीं है, फॉर एग्जांपल कोई मेटाबॉलिक कॉज तो नहीं है जिसकी वजह से पेशेंट रेस्पिरेटरी रेट ज़्यादा है, टेकिपनिक है पेशेंट. फॉर एग्जांपल इन डीके एक सिनेरियो था डीके का, उसमें तो once you treat the acidosis, the patient's respiratory rate will settle, so that patient does not need oxygen. एक्यूट इंडिकेशन जो इसमें सबसे एब्सोल्यूट इंडिकेशन है, दैट इज़ हाइपोक्सीमिया, PaO2 less than 60 or on pulse oximetry if it is less than 90%. Severe trauma, severe acute anemia, acute MI with hypoxia. MI में अगर hypoxia नहीं है तो again it is not an indication for oxygen. If the patient is in shock with acidosis, then that is again another indication. Long-term oxygen therapy mostly is used in COPD patients who are having PaO2 less than 55 or saturation of less than 88%. There are certain other indications as well. for patients having PO2 between 55 to 59 if they are having peripheral edema, polycythemia or P pulmonale on ECG. So, in most patients we target for 94 to 98% in type 1 respiratory failure patient. In patients who are in type 2 respiratory failure or who are at risk of having type 2 respiratory failure, the aim will be to target for 88 to 92%. Use the lowest oxygen needed. अगर इस रेंज से बाहर जाता है, फॉर एग्जांपल you have set the target 94 to 98% and patient is saturating 99 100%, you can reduce the flow. These are various devices which you can use to start the oxygen therapy. If it is mild hypoxia, patient is in the range of 85 to 90%, then you can start with nasal cannula. Start with 2 liter flow and gradually increase it if needed to maintain the target saturation levels. Simple face mask is the next option. If the patient is not able to maintain the required oxygen level, then you can shift to simple face mask at 5 to 10 liters per minute. But for patients who have got saturation less than 85%, who are in shock, you have to start with non-rebreather mask initially, and then you can down titrate depending upon the response. You have to consider the risk factors for type 2 respiratory failure, because in those patients, if we give high flow oxygen, then they are at risk of worsening of type 2 respiratory failure, going into respiratory acidosis, and then they may end up needing invasive ventilation. So, these are the risk factors. If there is previous history of type 2 respiratory failure, any previous history of admission with type 2 respiratory failure needing non-invasive ventilation, then these patients, when they come for subsequent visit, their target should be set at 88 to 92. Similarly, severe or moderate COPD patients who are already on NIV at home or long-term oxygen therapy at home. Similarly, neuromuscular and chest wall disease patient, they are usually in chronic type 2 respiratory failure once the disease is advanced. Another way by which you can give controlled oxygen is Venturi mask. So, इसमें जो इस तरह के पोर्ट्स होते हैं मास्क के साथ दे लग जाते हैं, बट फॉर एवरी पोर्ट देयर इज स्पेसिफिक फ्लो एयर फ्लो विच नीड्स टू बी मेंटेन्ड टू गिव ऑक्सीजन एट दैट पर्टिकुलर percentage. So, they are very useful when you need to give controlled oxygen, like for example in COPD patients. For last few years, we have been using high flow nasal cannula. This device can give oxygen flow up to 60 liters per minute. So, high flow oxygen is given up to 60 liters per minute. The oxygen is heated and humidified. Benefits are the patient tolerance is good. Some patient कुछ पेशेंट होते हैं जिनको ऑक्सीजन के साथ साथ हाई फ्लो की भी ज़रूरत होती है. फॉर एग्जांपल पेशेंट्स इन हार्ट फेलियर, पेशेंट्स हैविंग इंटरस्टिशियल लंग डिजीज़, पेशेंट्स हैविंग निमोनिया. सो इन दीज पेशेंट्स high flow nasal oxygen can prevent intubation sometime, and it improves patient comfort as well. So, for monitoring, usual monitoring, regular vitals and ABGs when clinically indicated, whenever there is change in the clinical condition of the patient, if there is a deterioration, if there is change in oxygen saturation of more than 3 to 4%, then ABGs should be repeated. Or if the patient is on NIV and you have changed the setting, the ABGs should be repeated. And look out for side effects of treatment like dry mucosa, pressure sores from mask when NIV is being used. So it is a team-based approach. The management of respiratory failure, doctors diagnose and guide treatment, nurses monitor and administer oxygen and treatment, and respiratory therapists, they are involved and helpful in setting up devices, NIV care and monitoring as well. Good communication, good monitoring is important for better outcomes for the patient. So early recognition is the key, and you have to classify whether patient is in type 1 or type 2 respiratory failure, and selection of appropriate device for each patient is important. Monitoring, continuous monitoring and adjustment of treatment depending upon the response of the patient is helpful.